Hello, dear colleagues. My name is Eleni Georgakopoulou. I am an oral medicine specialist. I live in Athens, Greece. And I would like to thank the committee of the POPCON 2025 for inviting me to present this very interesting topic about the therapeutic strategies for oral inflammatory disorders. What I will discuss is how we approach the patient with various oral inflammatory disorders. This is a very wide group, a very diverse group, which includes chronic inflammatory diseases like oral lichen planus, chronic autoimmune diseases like pemphigus vulgaris, mucous membrane pemphigoid, recurrent after stomatitis as well, graft versus host disease, oral mucositis due to chemotherapy or radiotherapy, as well as entities like severe or non-severe localized oral drug eruptions, viral eruptions, and immune-mediated conditions in general. These conditions share some common aspects. They all cause pain. Usually they're associated with ulceration, impaired function of the oral cavity. Patients cannot eat, patients cannot drink, they have difficulty in speaking. That involves a lot of anxiety and deeply affects the quality of life. The oral pathologists don't just diagnose these conditions. In many cases, they are the doctors who are responsible for curing and relieving the symptoms of the patients. So the therapy is in the hands of the oral pathology in many settings around the world. And we have to be aware as well that sometimes we have to begin an, let's say, empirical therapy before the final diagnosis is established. And sometimes, even if we don't have a precise diagnosis, we still have to help the patient because eating and drinking and functioning with their mouth, it is essential part of everyday life. I have prepared this stepwise algorithm of therapeutic principles. It is a very common sense approach. First of all, when we deal with the patients with lesions of the mouth, painful lesions of the mouth, we have to take into account the location and the extent of the lesions. So it is different approach if we have localized ulceration or if we have widespread extensive ulceration. What are the surface area involved? Do we have small areas? Do we have large areas? Respectively, we're going to start with different topical or systemic approaches. Do we have any systemic indications or contraindications? This has to be taken into account. Also, we have to be very aware of the patient's general condition, the patient's needs, and also the patient's choices. For example, as silly as it may sound, some people may not feel comfortable using an intraoral gel. They may prefer to use a rinse. It is more familiar because they're familiar with mouthwashes, etc. We will see case-by-case scenarios. When we have a patient with small size lesions, limited lesions, the first choice is always the topical. What is the first line of topical treatment we have for inflammatory conditions of the mouth? Corticosteroids. Usual types of corticosteroids applied in the mouth are triamcinolone, clobetasol, and dexamethasone in various forms. They have a more localized effect and fewer systemic side effects. Of course, there are limitations, and the most common problem with topical corticosteroids is the risk of the patient developing candidiasis. Candidosis, candidiasis, you can call it with different accent. How we choose the correct topical steroid? There is a quality of the steroids which is called potency. How potent is the steroid we're going to use? Depending on the type of the lesion, we will choose a less potent or a more potent corticosteroid. For example, when we deal with oral aphthous ulcers, the first choice is a medium potency steroid like triamcinolone acetonide, commonly used in adhesive pastes. There are ready-made pastes for this type of use. If we're dealing with a severe form of localized lichenoid lesion, we can rely to more potent steroids like fluocinamide or clobetasol, either in the form of adhesive paste or in the form of a gel with less adhesive properties depending on the lesion. When we have, let's say, localized small erosive lesions like recurrent after stomatitis, triamcinolone, a less potent steroid in adhesive paste, which can be applied to the ulcer, stick to the ulcer, alleviate the pain, protect the area of the ulcer from being touched by other by food or by teeth or by a prosthesis. It is very helpful and very effective. We don't need to use a more potent one. In the case of desquamative gingivitis, let's say in a patient with oral lichen planus, a gel may be preferred because a gel is more gentle for the gingiva. It doesn't stick like the more sticky forms like oral-based products. It can be used with splints that are ready, custom made for the patient sometimes if we have extensive lesions. And it is relieving even as a medium. It is refreshing, it is moisturizing, the patient feels comfortable to use it. And if we have widespread erosive lichen planus or oral mucositis, it's not easy to apply something topical all over the mouth like a gel or a paste. So we may use a mouth rinse with a potent steroid like dexamethasone. Here I present a case. It is an oral lichenoid lesion of the upper lip and gingiva, which was treated with topical clobetasol. It was a great outcome with a few days of application. Topical immunomodulatory agents that are not corticosteroids. A good choice is the topical calcineurin inhibitors. We have a lot of references that support the effective and safe use of this steroid, of these non-steroidal topical agents. They have high efficacy. They avoid some of the side effects of topical steroids like steroid atrophy if we have prolonged use. and can be used as a second-line topical treatment in cases where steroids don't work. We have some contraindications. We have cases where patients complain of burning sensation. They are a bit stingy, especially the ready-made products like the creams and the ointments that are not um, prepared for the oral mucosa. And we need to take care of the topical side effects. They don't have a risk of candidosis. And the previous warning regarding the development of oral squamous cell carcinoma, especially in patients with oral lichen planus, it seems to be a problem that is not that severe. Most of the that was a rather old um, case report regarding development of oral squamous cell carcinoma in oral lichen planus patients that used topical calcineurin inhibitors. More recent studies support the safety of these agents in topical forms for oral lichen planus. And we can use them with short-term or even long-term modes of application, and we can use from with interchangeable with topical corticosteroids. A good indication where these agents are very useful and they can work very well in cases where topical steroids don't work are the cases of cheilitis, like atopic cheilitis, like exfoliative cheilitis, where topical tacrolimus as an ointment, as a ready-made product, can be applied, like in this case, and control the symptoms. A lot of patients with oral inflammatory conditions, they have a superinfection with candida. Candida can either be a result of the inflammatory condition. It is very common to have a combination of oral lichen planus and candidosis, for example, or in cases with oral mucositis, we have a superinfection with candidosis. So a lot of patients with oral inflammatory conditions require treatment with antifungals, either as part of the control of the disease or in order to avoid the side effects of other topical agents like topical corticosteroids. Very useful topical antifungals are nystatin, which can be found as oral suspension. It can be found as a gel, as a cream. In the same sense, miconazole gel can be found as the tablets which dissolve in the mouth, and they have indications where they can be combined with either topical or systemic treatments. Chlorhexidine has a low but considerable antifungal action, and it is very useful because nowadays we have some shortages of the other two most commonly used topical antifungals, nystatin and miconazole. Here we see a classic chronic erythematous candidosis in a patient who was using anti-TNFs for other systemic condition. And we chose a topical nystatin for the lesions were because the lesions were mild, and in order to avoid any systemic side effects of systemic antifungals. We can also combine, as I mentioned, the topical agents. For example, OLP with candidosis, very common. We can use a topical clobetasol gel and nystatin suspension. Pemphigus vulgaris erosions, which are mild during a recession phase. We can use dexamethasone mouth rinse and miconazole gel. Desquamative gingivitis with secondary candida, we can use a combination of triamcinolone plus nystatin on a single paste. And in some cases where we have candidiasis, either as a result of another inflammatory condition or secondary to another anti-inflammatory treatment, we can use nystatin solution as a monotherapy. Here we have a typical example of secondary candida superinfection in a patient with allergic reaction. The management required both potent topical corticosteroids and topical antifungal therapy, and we had a very good clinical improvement. In the treatment of oral diseases, sometimes we don't have enough ready-made products that are specifically designed and prepared for the mouth. So sometimes we have to use what we call galenics formulations, which is a form of drug that the pharmacist has to prepare specifically according to our directions for the patients. These are essential part of many oral mucosal diseases treatment, as we don't have a lot of specifically designed for the mouth ready-made products. We have, for example, some paste with antifungals and steroids as a ready-made paste. But in the galenics, we can use any compound we want, a gel, a solution, an Nora-based paste, which is more stable and more able to keep the drug on the site of the lesion in the oral cavity, where we have a lot of saliva, and this causes a lot of creams and gels to be diluted. So we have oral-based adhesive paste. We have gels that are made for the mucosa. We have mouth rinses. We can use different combination of mouth rinses, and we can incorporate corticosteroids, calcineurin inhibitors, antifungals in these compounds. So we have the oral-based and oral-based plus the Nolea-based gels here in Greece, which are the most commonly used compounds for the mouth worldwide. They improve adhesion and stability of the drug delivery. What I said, inside the mouth we have the saliva, and will dilute any cream and gel that is not designed to be used in the mouth. And we can use any type of medication we wish for the specific case. Here again, a clinical example. We have a combination of clobetasol and nystatin for this case of desquamative gingivitis and also for the ulceration of the lips. When we cannot control the inflammatory condition with topical steroids, we have to choose some systemic treatment. The most commonly used systemic treatment for oral inflammatory conditions are the systemic corticosteroids. The number one steroid used worldwide for oral mucosal diseases is prednisolone. It has clear indication for severe erosive oral lichen planus, for pemphigus vulgaris, and for mucous membrane pemphigoid. Usually we start with a medium dose of 20 to 30 milligrams per day and we taper. Sometimes, if we have more severe cases like severe pemphigus vulgaris, we may use IV pulse therapy, high doses. Which is the mechanism of action of steroids? A short review. They reduce capillary permeability, histamine and kinins. They influence immunomodulation, and they act by genomic and non-genomic pathways. Remember that all systemic corticosteroids are glucocorticoids. They are used because they have anti-inflammatory and immunosuppressive properties, and some of the most commonly used drugs are the prednisolone, methylprednisolone, deflazacort, especially in the UK, and dexamethasone. Some aspects we need to know when we choose the correct corticosteroid. We have to be aware of what is the normal cortisol secretion. A daily cortisol secretion in a healthy patient is about 20 milligrams of cortisol per day, and this is the morning peak. Synthetic corticosteroids mimic cortisol. They are absorbed in the jejunum, bind to plasma proteins, transcortin albumin, and they release the active form, the free glucocorticoid. As we mentioned, they have anti-inflammatory effects, reduce capillary permeability, phagocytosis, antigen presentation, very important for autoimmune condition. They suppress histamine and kinin release for mediators of inflammation, and they reduce lymphocytes and eosinophils. How they act in a genomic way, via the glucocorticoid receptors in the nucleus, they affect gene transcription regarding genes of inflammation. Transactivation of anti-inflammatory mediators is boosted, and we have a repression of other pro-inflammatory mediators. The non-genomic are more rapid effects. They are membranes of the cells and signaling pathways. It is important to know that we have an increase in the number of neutrophils. So sometimes when we prescribe for long-term use corticosteroids, that will be seen in the full blood count. So we don't have to worry. We have to inform the patient that a rise in the neutrophils is normal. It's not an infection necessarily if they see high neutrophils after the prescription of corticosteroids. Usually, as you mentioned, for example, in severe forms of oral lichen planus, we use prednisolone in 20 to 30 milligrams daily doses. If we have cases of severe diseases where we need to administer more than 50 milligrams of prednisolone per day, we can use intramuscular injections and not pills or solutions. Other choices are methylprednisolone, especially for IV pulse therapy, for the case of pemphigus vulgaris, for example, where we have severe cases that are hospitalized. We have to be aware that these agents have severe side effects. We have a lot of known and well-described side effects. So this is both an advantage and a disadvantage because although they have a long profile of side effects, these are all well known, well described, and we can be prepared for the side effects and we can address the side effects. For example, we can control diabetes, which is related to glucocorticoid. We can prevent peptic ulcers with GI protection. We can control hypertension. We can control blood pressure of the eye. We can prescribe treatment prevention for osteoporosis. And of course, we advise the patients to be careful not to be exposed to possible sites of infection. We should monitor always the patient's blood pressure regularly, check for glucose levels, check for full blood count, and in cases of more than 3 months of prescription, we should check for bone density. A regular exam, again, ophthalmic exam, weight and height exam, calcium and vitamin D levels, all these are indicated for patients that are going to be on corticosteroids for more than 3 months. Therapeutic rules regarding systemic steroids. We should prefer the morning doses because they mimic cortisol rhythm. We should start with high doses so we achieve the fastest result as possible. And what we intend to do is to taper as soon as possible. A good choice is the alternate day therapy. So we use different doses each day so that we avoid this common side effect of adrenal suppression. And if we don't have a response as soon as we expect with high doses of steroids, we should consider adding a steroid sparing agent, which we'll discuss later. Which are the evidence regarding the most common applications of systemic steroids for oral diseases? So we have good evidence regarding pemphigus vulgaris. We have good evidence regarding pemphigoid, but not as good as for pemphigus. We have limited evidence-based, but a lot of practical experience with oral lichen planus. It is a widespread use of systemic steroids for severe forms of oral lichen planus. We don't have enough evidence regarding aphthostomatitis, but in cases of major aphthostomatitis, we have a lot of case reports which support the successful use of systemic steroids. It is more complicated with erythema multiforme. Some literature supports the use of steroids. Some literature is only advising supportive treatment for patients with erythema multiforme because the lesions can be self-limiting. But it is true that in order to help the patient alleviate the severe symptoms of erythema multiforme and help the lesions heal faster, a medium to high dose of systemic steroids for a short period of time can be helpful. And we have some low evidence for the orofacial symptoms of sarcoidosis. Here we have, I don't know if it is very visible, we have a patient with pemphigus, severe erosions in the soft palate, extending to the buccal mucosa and the oropharynx. After 1 month of monotherapy with dexamethasone, the lesions cleared. We had minimum flare-ups during the tapering period. The patient is on very, very low dose, very well monitored. We want new types of steroids. We had the pandemic, which stopped a lot of research regarding the development of new corticosteroids with more selective action. We don't expect large randomized controlled trials for cases like ours. We have to be realistic. We don't have a lot of research fund and safety background to do innovative research regarding steroid and non-steroid or new steroid treatments on our cases, large RCTs with hundreds of patients. But we have a good chance if we do good multicenter studies, good multicenter retrospective studies or prospective studies, or to do some good meta-analysis of retrospective or prospective cases to develop more evidence-based data. So we have a well-documented experience regarding the efficacy of corticosteroids in various severe oral inflammatory diseases. We have to be very careful with the monitoring of side effects, and prednisolone is the most commonly used agent. Now let's talk a bit about the steroid-sparing agents like azathioprine, mycophenolate mofetil, dapsone, and some others like the calcineurin inhibitors, systemic medication. These are used in cases of severe pemphigus, severe mucous membrane pemphigoid, and in some cases of extensive oral lesions in Behçet disease. It's other agents we have less commonly used. Thalidomide. You remember thalidomide for the side effects on the developmental anomalies of the limbs. This agent is very useful for severe aphthous ulcers in Behçet disease. Colchicine, which can cause sterility in males. It is a good choice for patients with Behçet disease. Cyclophosphamide, a chemotherapy agent, indeed. It is used in severe cases of pemphigus vulgaris and some vasculitis with severe and extensive oral ulcers. Biologics. We have limited evidence for most of the biologics regarding oral disease, but we have an exception. The anti-CD20 agent rituximab is now considered one of the major players in the treatment of pemphigus vulgaris. Of course, it is a very expensive treatment. It has to be monitored in centers where they have experience with the use of rituximab, but more and more doctors rely to rituximab for the control of pemphigus, avoiding the long-term use of corticosteroids and the side effects of corticosteroids in patients with pemphigus vulgaris. Of course, the cost is very high, and we have to be very careful with the monitoring of patients because severe infections are a possible and dangerous side effect. What are the practical challenges when we deal with oral inflammatory conditions? The first, as I mentioned, is the availability of oral mucosa-specific drugs. We don't have a lot of drugs that are designed for the environment of the mouth, and we have to be sometimes very innovative. We rely a lot on the patient's compliance, and that is very important for the topical treatments, because the topical treatments sometimes require application 3 or 4 times a day in order to be effective. We have to familiarize a little bit more with the galenic preparations, which are essential in practice, and we have to insist on learning how to prescribe them correctly, how to collaborate with pharmacists in order to prepare them correctly, and how to explain the instructions with details to the patient so they apply it correctly. Let's hope that in the future we will have more sophisticated treatments and mediums of application of treatments. We believe a lot in nanotechnology, control release treatment systems, and we have some of these, for example, in periodontitis with all the topical control release system for chlorhexidine and minocycline. And let's hope that we will have better funding and better collaboration between different institutions worldwide, so we have better evidence for the application of treatments for oral mucosal inflammatory diseases. So I hope I gave you a good sum up of how we approach oral inflammation. I wish you feel more confident to treat your patients and self-sufficient in the management, because the oral pathologists are very self-sufficient in the diagnosis. And I hope that as neural medicine specialist, I can help you strengthen your professional autonomy, because a lot of patients in many areas rely on the oral pathology to help them as well with the management of the treatment, and indeed it is the best specialist to help them. So the take-home message is try the stepwise therapy to improve, to achieve the best treatment with the most safety. Always think topical first, but don't waste time on topical agents in cases of severe cases. Try to find access to biologic agents like rituximab in cases of severe pemphigus when you can. And always monitor as close as you can your patients to prevent complication. I know it's not easy because some patients travel a lot in order to see a specialist, so you will have to rely on that to the topical doctors, to the doctors in the local doctors, to have a good communication in order to help you monitor the side effects of the patients, which require long-term use either of topical or systemic agents. There is a series of articles from me and Professor Scali regarding the treatment of oral inflammatory disease with systemic agents in oral diseases, and a very good Cochrane review by Professor Lodi. I want to thank you for your attention. I hope I didn't make it very boring. Lots of love from Athens, Greece, and of course, I declare no conflicts of interest.